All right, we're going to get started. I'm Laura Sideri. This is going to be my final meeting that I will be leading as our co-director or our co-chair for the CoCM SIG. It's been such a pleasure to be serving in this role for the last couple of years. I know also Monica Harrison has also been my co-chair, and she's going to be outgoing and doing more of the board of directors work. Ben Hilliard. He's going to be stepping up to the co-chair role. And I would like to announce today our two elected incoming team members. We have Ashley Shattuck. Ashley, I see you there. Can you come off mute?
Hi, surprise.
All right. And are you co-chair? You're secretary.
Secretary.
And then we have Annie McGuire, who's our new co-chair.
Hi, everyone. Thanks. I'm really excited for this opportunity.
Me too. High five, Annie.
It was an excellent, excellent election. There were so many great votes, and we're so thankful to have you both awesome leaders leading up. You guys will be in good hands, and I will be looking forward to being on the other side of listening and learning and collaborating in these meetings. So we'll be deciding upon the next date. We may keep Wednesdays at this time or may change. We're going to be taking a closer look and be on the lookout for like surveys or other things that might come out just to make sure that this time still works for folks. All right. So we've got an awesome conversation today. A common question that comes up for collaborative care is how is CoCM able to be done in different states and different regions of the country? What are the facilitators and what are the barriers? So we've got team members from two different parts of the country that are going to be talking today. I'd first like to introduce Amy Jones and Danielle Gadbois from my wonderful state of New York. Can you guys introduce yourselves and share just maybe like 30 seconds to 1 minute about your work in New York State?
Sure. So my name is Amy Jones. I'm the Director of Primary Care and Behavioral Health Integration for the State Office of Mental Health, which is our state mental health agency here in New York. As part of that role, I've helped develop our collaborative care Medicaid program and the Medicaid and technical support and adoption and implementation assistance throughout the state over the last almost 11 years that we've had that program. We're really proud of the pioneering work we've done around CoCM in New York State, and I couldn't do it without Danielle, very literally. Just don't know what I would do at this point. She helps keep us rolling as well for almost a decade now. Danielle, do you want to say hi?
Sure. Hi, I'm Danielle Gadbois. I'm the Behavioral Health Integration Program Manager here at the Office of Mental Health, working with Amy on all things collaborative care, supporting sites with data, billing, technical assistance, all the things. So thanks for having us.
We're going to have an awesome conversation today. Before we get started, I also want to introduce Dr. Patty Gibson from Arkansas. I don't know if Caitlyn Johnson's able to join from ABHIN, but talk a little bit for an intro for you, Patty.
Yeah, Caitlyn's trying to get on. She's doing that last minute. So Patty Gibson, I'm an adult psychiatrist in Little Rock, Arkansas, and have been learning about CoCM for years, and CFHA has been a huge part of that. I co-founded ABHIN, Arkansas Behavioral Health Integration Network, around 2018 with Kim Schuler, who's actually involved in a grant meeting right this minute. And also Caitlyn Johnson is on here, and we work together in a CPC Plus initiative at the Baptist hospital system. And I've the last 2 years been the medical director for behavioral health at Arkansas Blue Cross Blue Shield because and the reason nobody goes to med school to go work for an insurance company, but the reason I did was because I see payment as a huge, huge barrier for all integrated care and particularly CoCM. And even though Arkansas Blue Cross pays those codes in the state, it's still a huge issue. And I really am not liking the way having to use CPT codes and fee for service. But I'm not as day-to-day involved in ABIN, but certainly can talk about things that are happening in the state. Caitlyn made it.
Caitlyn, can you introduce yourself?
I sure can. I'm sorry I'm late. Trying to do too many things at once and couldn't find a link. So I'm Caitlyn Johnson. I'm an LCSW. I'm a social worker by training. And I work as a project manager for ABIN. But my most of my clinical career has been in integration. I like to say that I was raised in the PCBH model because that's what I did under Dr. Gibson at Baptist. But now that I'm doing project management and have been on the CoCM grant with the state of Arkansas, I have been able to work in the CoCM sphere, which has been super rewarding. It's been great to see, what I'm passionate about already as integration, being able to spread and touch even more lives than we've been able to see before. So that's what I do. I work also as a trainer for ABIN as well. So I get to work with the behavioral health care managers at these sites that we work with hire, and I get to be involved in a lot of the training as far as brief intervention and how to manage caseloads and how to work with the psychiatric consultant, which Dr. Sideri also helps us with as far as training. So that's me. Again, I'm so sorry I'm late.
You came in at the perfect time, right on time for your introduction. So let's dive right in and have a conversation. Let's start New York State. What do you think's been working in New York State, and why has it been working?
I put together a couple slides, Laura. I mean, nothing groundbreaking.
Oh, go ahead, Amy.
Do you want me to do that or no?
Yeah, absolutely.
Okay. All right. Laura gave me a little bit of a heads up on some of the things that she thought might be helpful for this group. Let's see if I can. Okay. All right. Can you guys see these? Yes.
Looks great.
Okay. Is it the wrong screen or is it the right screen?
It's the notes screen.
It's the note screen. Okay, hang on. Let's flop it. Swap. There we go. Good.
There it is.
All right,
Good.
cool. All right. So again, really high level. I think these are some of the things that we found unique to New York State that have worked really well for us. And again, Laura has some personal experience with some of these things, so she may have a different perspective from the practice and provider side. So this map is as of 407. I think we're like 413, Danielle. Does that sound right?
Yeah, this is earlier this month, but there's been a couple since then, yeah.
Ooh, so yeah, we have over 400 practices in New York State that we support and coordinate that are doing collaborative care, have submitted and been approved by us to do so and bill Medicaid. We've had Medicaid reimbursement for context since 2015 formally in New York State. So a lot of our work predated some of the federal work for Medicare and the CPT codes and that sort of thing. So we've seen a lot of evolution and growth and change over the years. One of the unique things that we do that we have found to be really valuable is we do have an application process. So some of it is just more of an attestation, but there is kind of a goalpost that you have to clear to bill Medicaid in New York State. So this allows us to have some level of standardization to really make sure that folks understand the collaborative care model. You think that would be a no-brainer, but we consistently have people come to us still today that are like, oh yeah, I want to do collaborative care. I'm billing, we bill Medicare, and we look at some of their processes and it probably wouldn't pass muster if things like they don't really have a registry or they don't use site consultation in the way that it is designed in the evidence base of the model. So we kind of go through that process with them, and we found that really valuable in helping to ensure that they have all the pieces in place, and then we know who they are, which makes some of the other things possible as well. We do collect process and outcomes data from all of our sites that are doing collaborative care. These are the metrics that we have defined that we collect from everyone. So everyone approved through that application process reports their data quarterly to us. We get monthly aggregate site level data. So it's not patient level, but it still is really, really valuable in that it helps keep them accountable to fidelity to the model. It lets us know how people are doing. It's been really valuable from the state and program perspective to be able to say, hey, this is how many patients we're really reaching. These are the results that we're seeing, to encourage, growth and support at the agency level for the program, and to be able to share that nationally, with some folks like yourselves in different forums. So just, for continued program sustainability, it has been helpful. And then we also use it to provide training and QI support. So, some of it is pretty straightforward, and some of it we have kind of certain things will be an indicator or like a canary in the coal mine, if you will, about where some things may be departing from the fidelity, or at least from what we know is a best practice or gets the best outcomes, to really optimize collaborative care. So, a lot of these individual things work on their own and together to tell us a little bit of the story of what's going on with their implementation. And so we can use these to help support them. And if they're receiving coaching or doing any training, they're great metrics to be able to use as a jumping off point to say, like, hey, your engagement percentage is a little low. Maybe that's an area that we can, work on with you, to really help. Or maybe that's a reason why, you're seeing some of the outcomes that you're seeing in collaborative care. So these are really, really valuable for us on a number of levels. And the degree to which we collect data and how we use data, to my knowledge, is also pretty unique in New York State. So just giving you kind of the tops of the trees, but happy to say more. And then the last thing I would say,
one
go
question
ahead.
we have coming up from Annie. So she
Sure.
said in other states, the attestation has been a barrier because of the long review process.
Mm.
What have been the keys to efficiency with the attestation process in New York?
That's a great question, and is framed as a compliment. I'm glad that it's efficient. So the attestation process for us is pretty straightforward. There is like a couple page application. Some of it is about collecting the billing information that we need in order to kind of turn on the ability to submit claims on the back end of our Medicaid billing system. And then some of it is about collaborative care, like the workflow and different things. One, I would say, is we provide support through that process. So it's not just kind of unilateral where they'll submit it and it's accepted or rejected. So we work with them if there are things that don't quite meet the criteria, like workflow, for example. Sometimes we have to kind of get follow up on that, or they have questions about what meets the criteria for a registry, and we can kind of work with them on that and provide some support. The other thing is, and we frankly have a very small team. Danielle and I are 2/3 of the team, and that's we used to be 100% of the team until about a year ago. So there's not a lot of layers of approval that it has to go to. It goes right to the source, programmatically to us, and we're able to evaluate it and kind of process it from there. So, hopefully that's small but mighty for
As
sure.
someone going through the process, I have to just say thank you so much to you guys. I mean, anytime there's a question, email, jump on a call. I mean, the responsiveness, you wouldn't know that it's just, and I think is the third one, Liz Roberts.
Yes,
Right.
yes, Liz is number 3, yeah.
The customer service, the like different layers of support that you guys offer helps so much, regardless of what stage you're in. Verna Little also on this call, technical
Yes.
consultant offered by New York State. Like, you shared you've been doing this since 2015. This takes time and experience to build, but such a testament to what you guys have built to support New York State. It really made such a difference for my team getting started out.
Well, thanks, Laura. You set me up for my third thing. Perfectly, is we do provide pretty comprehensive technical assistance. We're very fortunate to be able to do so, but it has been pretty essential. And again, we're constantly kind of growing and learning ourselves. So this grew out of a academic medical center training grant that had 33 practices doing collaborative care, and we now have over 400. Obviously, that's a decade of work, but we have learned also as we've gone on and are constantly reevaluating our processes and what sites need, and that evolves all the time. We're really lucky to be able to have experts like Verna, who, really is a fourth member of the team at this point. We also work very closely with the folks at the University of Washington Ames Center to provide support. And it's really very, I mean, customized maybe isn't the right word, but kind of tailored to whatever the sites need. So I always use the silly anecdote that if they can get all the pieces on the game board or the players on the field, we'll do whatever they need to kind of teach them the game and teach them how to win. So, we'll train the players in their positions and teach them the rules and how to be successful, depending on, to what degree they need that. Help with their workflow, do those clinical skills trainings. We have some, CME provision with things. We have some self-paced modules, as well as, live training, one-on-one coaching with experts like Verna and folks that she collaborates with. Billing support, I can't stress that enough. That's one of the things that I was going to comment on later, but really can't say too much that the support for financial sustainability is probably one of the areas we provide the most technical assistance on. We have done basically a monthly webinar almost every month for 10 years on some different topic. We did do office hours, but having like a formal office hour session proved to be kind of underutilized, since we have so much kind of open availability just as questions come up. So we've discontinued that for now, and are just ad hoc available. And then the last note I made here is we don't currently have any time limits, which I'm sure Verna could say a lot about, and we have some feelings about too. It is kind of always available in perpetuity, which I think is a great service and has been really valuable. I mean, sometimes practices have turnover, need to retrain even after doing collaborative care for years, but also sometimes it removes the sense of urgency for implementation, and people can kind of stall and lose momentum. I think can really be the death of a program, or a sign of lack of engagement in other places, just a symptom of larger challenges. So having no time limits or limits on utilization of support is sometimes a bad thing, but in general, I think it's been really valuable. I'm trying to see if there are.
Excellent points. The land of perpetual launch.
Yes.
Yes, Verna, you've coined that phrase, and it's been ingrained in my head since the beginning too. Can you talk a little bit about the legislative funding? We got a question.
Sure, I saw Patty's question. Yeah, Patty, we're always trying to connect with Arkansas, so this is great. So we have a recurring budgetary allocation that is a part of the state Medicaid budget. We did get a state plan amendment, which we submitted in 2014 to establish this program and establish at the time new unique rate codes for collaborative care. And so that did go through CMS to be added to the Medicaid fee schedule. And we have an allocation to pay those claims. We do carve out resources from other just kind of discretionary funding that OMH has annually to provide the technical assistance and be able to work with experts like Verna and Ames and others, and then to pay for us doing it. Again, for the 400 sites, it's been mainly the two of us, and then we have a SAMHSA grant right now, are also in that as a state. And so that allowed us to bring on some additional support around the grant. But so that has been in the budget since 2014. And it's, I guess, permanent funding as much as anything in the Medicaid budget could be.
What is the business case, and what makes the business case? There's a question in here on return on investment.
Yeah,
what really makes the difference?
So for us, the reason that this all got started is, like I said, we had that we had a really passionate leader at the time about integrated care that I think was, a pioneer in the field, and really wanted to see this model grow, and embedded it as part of this PCMH project that our state was doing, and had some sites pilot collaborative care. And so during that time, they collected outcomes data and kind of made their own case for, patients improving, and just the kind of provider experience of having this service available. And at the end of that time, there was really an appetite to continue, but they said, hey, we really don't have a way to sustain this. There's no sustainability method, for how we can build for this service, since it doesn't really fit into any of
If
the
I were
structured
to
buckets.
say a couple of things,
Yeah, go ahead. But so anyway, that it really was more of an outcomes experience case to begin with than a business case. Over the years, we've done more and more financial evaluation, and we're in the process of finalizing a Medicaid claims analysis right now that hopefully will be submitted and publicly available next year. For the most part, we found our real world data to be pretty much in line with the randomized control trial information, that around 3 years, you start to see a little bit of a financial offset, and that the savings are mostly deferred physical health, emergency room utilization, and things of that nature. I also think it does fit really well into, to your earlier point, Patty, about some of the value-based ways that health plans and others are trying to encourage care. So although it's not direct, if they are trying to meet some of those metrics in more value-driven care, collaborative care is definitely one way to get there. So that could be another kind of financial incentive. But I will say, I think other than the fact that we do find it to be financially sustainable and it's a service that you can provide and get at least break even on, I don't know that I've seen a lot of other or needed a lot of other ROI information. The question is just usually like, can we pay for this? Can we afford it? And it can. And so that's usually the big finance, ROI question that we get. I don't see any other questions. I was just going to go through. I know Laura was talking kind of about lessons learned. I'm happy to answer any other questions. But in general, I would say the main things that we still struggle with, like I said, billing, 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 billing. We provide a lot of support around just claim submission down to how do I complete this claim in my EMR, trying to be familiar or identify resources in various EMRs. And Laura knows this all too well, that I'm sure you all have talked about in this group, over time, that there almost always is some sort of manual process. And I think many systems in many different EMRs are trying to work on a solution for that. But there almost always, when it comes down to it, is some human component, since it's that monthly claim and there's time that has to be accumulated, and different levels of time and the add-on and all of that kind of stuff, that it just doesn't fit with the way that we have set up the manual kind of check a box, and it goes out for service-based billing. So that can be really complex. And we try to provide support across all payers. We can only audit Medicaid claims, and we do try to track that. Generally, I mean, Danielle can tell you more specifically, but we do find that even among the Medicaid claims, people aren't even billing 100% of the patients that they would be eligible to provide care, to meet the billing criteria for, that they are providing care to for collaborative care. So I just can't underscore that enough. I don't have the magic bullet on that, but we do a lot of support, because I always say, the best evidence-based practice is only so good if people aren't going to be able to pay for it because it's just not going to be sustained, for sure. Um, we still have a challenge, in uptake. We have over 400 practices, but in New York State, that's only about 6% of primary care. It certainly isn't a one-size-fits-all model. We acknowledge that. I wouldn't expect anywhere near, 50% uptake. But hey, it'd be great to see 10 someday. And even doing this for 10 years, we are kind of barely scratching the surface. I think everyone seems to think on paper that it's great, but actually getting real world adoption and sustainability, and getting people to do it has been a challenge. I mean, obviously having the workforce is really key. Um, and the primary care buy-in piece, what are some of the factors? I see the question on that. I put this in here because sometimes people think like, oh, it's behavioral health integration. Um, but we find that behavioral health really shouldn't be in the driver's seat. It needs to be primary care centric because that PCP is like the front line, of engaging their staff and engage. And if they're not bought into this as a model, and they don't feel that it's working for them, it's just not going to stick long term based on our experience. So I think having them see some early successes, making sure that, patients are getting enrolled, um, that they feel like their patients' needs are being met, that their needs are being met, seeing that patients are getting better, having positive experiences and kind of the coordination, and addressing some of their pain points, I think can be really, really key. And even if it's finding, that one provider in a practice to kind of test it out before you roll it out, either to other providers' caseloads or other practices within a system or a state, having those champions can be really key, but you just want to make sure that it's centered in primary care also and not like behavioral health is coming in to do this program, which I think is sometimes really, really hard. There's no training requirement. So although in like things like the grant, that is sometimes pushback that we, have some deliverables. The training is available. Most of the training that we do in general is for the behavioral health care manager role. So their whole job usually is collaborative care. So making time for training, is usually just part of their onboarding and professional development. So that's less of a challenge than getting folks like the psychiatrist PCP on board. But that training is really important in any way that you can cross-train folks because we have seen turnover in the role and finding people, especially for that behavioral health care manager, that are a good fit for that. It's not just any behavioral health professional that is going to automatically fit to work in an integrated setting, in this really collaborative way with primary care that are doing short visits, that are using the telephone, that are doing frequent contacts, all that kind of stuff. Sometimes people have a certain mindset about like what mental health care or like therapy is, and just can't break out of that box. And so, that may be a limiting factor for collaborative care. But we have seen that be a challenge to sustainability when, people leave that are really key to the buy-in, or, only have one person be trained in the model. And then, that's a place where we have to kind of train them all over again. And then the last thing I have, and then I'll shut up, I promise. If you're looking to grow collaborative care, either from the state perspective or like a systems perspective, I think making sure you have Medicaid reimbursement obviously is key, but really looking at, are the rates sufficient? How do they compare to Medicare? How do they compare to the actual costs of care? In New York State, we're very fortunate to have finally just adjusted our rates for inflation for the first time in 10 years. And so that has really brought it up to a level that I think is much more in line with what, as far as the cost and utilization. The startup costs are real. It is possible to have 100% of the cost paid for. And with Verna's help, we do encourage folks to do a pro forma very early on in their implementation and think about the financing and what that looks like for them and what their goals are to build their caseload and to bill and that sort of thing. But sometimes if there are opportunities for even small financial incentives, that can soften the blow a little bit, and I think entice some providers to take that on. I know Julie mentioned earlier too, the EHR component is sometimes challenging depending on what EHR you use, being able to have something that functions as a registry to do that population health and that treatment to target tracking. And for us, because we do collect that data, having those data reports and being able to have, your data be utilized. So it's not just something that you're putting it into, but you're getting usable information back for your own information and QI. Sometimes things like that can cost money. It might be kind of a one-time investment, or getting that person hired and trained before they are having a billable caseload during those first couple months. So sometimes having startup funding can be really helpful if you have an opportunity for that. But you need to make sure it's sustainable, for sure. And then really educating people, and I think this group would be really good at this, but maybe it's not as clear for others as the differences between collaborative care and other mental health and integrated behavioral health approaches. And that, it isn't one size fits all, but also you don't have to pick just one. Ideally, you have a large menu of different places. So there are multiple doors and multiple choices for patients and providers, depending on needs and preferences for both. But sometimes people just kind of like pick one and feel like, okay, we can only do psychotherapy, or we do collaborative care, so we can't do this, or we can't have a BHC. And I think it's just important for systems and providers and just in general for folks to understand the differences, and even at the site level, like if you have multiple options, how are we going to triage folks? What's the appropriate patient for collaborative care and these other modalities? So really kind of differentiating it among the different options and how it fits is something that I would encourage people to think about as part of the education.
Yeah, we got a question in the comments. How do you advocate for better reimbursement rates with your state? And what do you start, or who do you start with? Who do you need to do a meeting? So, you shared some wonderful information about having a really great champion to begin with. Share a little bit about what we could do as everyday people, or how we can advocate in our different regions for these kind of excellent services.
Great question. Geez, I wish I had a definitive, this is exactly what you need to do roadmap. But I think, not to belabor it, but I think having data does really help to be able to make your case on whatever scale, whether it's moving it from one practice to multiple practices within your system, whether it's engaging, a hesitant provider in referring collaborative care, or whether it's more, statewide in getting reimbursement or technical assistance support or something to be able to say, hey, we like in New York State, we can say our improvement rates for patients are in line with the randomized control trials. We see 50% of patients approximately getting better, being in treatment for 10 weeks or more. We can say what our screening rates are and how many patients we're identifying, so we can, enumerate the need, essentially that there's a demand for it. And, we can demonstrate why certain elements are important, even like it's important to keep patients engaged because when we see engagement, that's when it's financially sustainable. So really the data helps kind of make the case at all stages. I would say, so, however small a scale that is, I think starting to get some of that data can really help. Whether it's, from an implementation or an advocacy perspective. I think it would be great in general to see more ROI data, even, for us. So we're hoping to contribute to that because, that is the question, but having that financial cost breakdown, like that formal back of the envelope type of thing of it mean, Verna can certainly attest to that. She's been key to that process, being able to make the case and have whoever the financial decision makers are involved, that, hey, you get good outcomes for patients and we can afford it. Like that should be a no-brainer right there, right? I know it's not always that easy, but go ahead, Verna.
Yeah, I would say, I just want to jump in. I think all that is key. Claire from Meadows and I actually keep the state grid with all the information around the states.
Yep.
And we are now targeting states that haven't passed the codes, states that have rates below Medicare. And we're also collecting a list of individuals from the states that we can call on for advocacy. And we're building out our 2026 strategic advocacy plan now for collaborative care. And so if any of you, it would be great to have your information, what state you're in, if you want to sort of be on that list. That is incredibly helpful. And if you want to advocate, reach out to us and we can get you connected with people in the state, or we can rally the troops and support you.
Yeah, and Verna knows I'm always a resource to the extent that that would be helpful. We've definitely talked to other states over the years about some of these types of things and answered questions for the program people or, the finance people to kind of say like, hey, this is what we did in New York State. We have 10 years of this. This is what's working. This is what hasn't worked. This is what's valuable. And I think, just showing that it can, that offer always stands. And Verna's a great resource to us too, to be able to kind of pull some of that national data sometimes about utilization. But at the end of the day, it's increasing access to mental health care. That's something that is, at least in our state, something that's of interest and I think has gotten more national attention in recent years. Sometimes maybe you have to find a priority population. Like our SAMHSA grant is focusing on youth, and youth mental health is obviously an area of interest for a lot of folks for, good/bad reason, because it really does need more support. So if that can make their case, if, that can be your into doing collaborative care. And I think there's more and more opportunities for priority populations too. So,
And I think a lot more with the Medicare support that's coming out with the Complete Care Act, with access that just dropped in the last 48 hours, which is huge for supporting collaborative care. And so I think that will help a lot of the states.
Cool.
Verna, could you share a little bit more about the news drop?
Yeah, I can actually put something in the chat. Sorry, I'm also watching a New York State webinar as we speak, monitoring that chat. So the yeah, CMS actually put out something that they're calling Access. I will put the link in the chat. It actually has several measures, and it is meant, one of them is around the PHQ, and vendors and organizations can actually sign up and participate in Access. And there is a webinar. So Access is the Advancing Chronic Care with Effective Scalable Solutions model that will launch July 1st, 2026. It's a 10-year voluntary program. You have to be a Part B provider, but it essentially is hypertension, high cholesterol, obesity, and of course, depression and anxiety are on there as well. And the payment is for a meaningful reduction in that PHQ or GAD score. So I'm actually working with my team today to put together a one-pager for information that I will share out probably tomorrow-ish on the CFHA website. So if people have any questions or whatever, then please feel free. I'm kind of wrapping my head around it last night, and I'll go to an information session. So I'm glad to be helpful, but most organizations should probably be all over this if you have a Medicare population.
Cool.
Could you drop that on the Basecamp group also, the message board, Verna, when you get that one pager done?
Yes, I can do that too.
And then the other question from Patty, does the state have to be the one to apply for access?
It's not a state, it's an organization, it's a provider. So states aren't eligible, only providers.
Okay. A couple years ago, there was one that we looked at in Arkansas with a multi-payer group, and we couldn't get the state to even. So it's like, and I thought it was called Access, or maybe it was called something else. So I hope this is new in the.
It is
within the
very
treatment
new.
provider.
Literally just hit the presses.
Awesome.
I think just about 48 hours ago. And this has some significant payment. So you do have to be a Part B participating organization. But I think I am putting some questions into CMS, particularly can an organization participate in just one measure like depression and anxiety, or do they need to participate in all? I see Jen Thomas put in the tech requirements. So there is actually something called TEFCA, which you have to participate in. And I will include that in the one pager. Basically, it has to go from an HIE to TEFCA, which I know more about today than I did yesterday. So I will include all of that in the one pager. But
we should have another future SIG meeting with this as a possible topic, or other kind of like big 2026
yeah,
things.
1,000%. I would say this in the Complete Care Act, which is very specifically collaborative care. And also if the advanced primary care works out, I would do that as well. Maybe like a 2026 advocacy agenda that Meadows and I could do, or some of these special things.
We'll bring it
And
back.
also, it's just like Amy was saying a minute ago, and actually, Amy, I wish I had a recording of you doing that. I mean, what a great presentation. And, you know, we've got all the behavioral health people convinced about this. So Verna and Laura and Monica, we almost need to have education for the decision makers, for
Let's transition, Patty, into you talking a little bit about Arkansas. You know,
And I'll do it for you live anytime, Patty.
Okay.
I think we could have another hour on just this conversation, and this was my poor time management for the planning. But let's share a little bit, Caitlyn and Patty, about where things are at with Arkansas. And, you know, let's start with maybe comparing to New York State. What is similar and what is different for Arkansas? And then we'll get into like kind of talking about ABHIN. But could you share a little bit about kind of the landscape and the climate in Arkansas right now?
Yeah, and Caitlyn may have a slide or two that will give a little bit more about what's happening. But also, I wanted to point out that so Arkansas right now, Medicaid does not pay for the codes. And there's people on this call that have been part of the history, and I want to call out Verna and Concert Health are in the Mercy system in Arkansas. That's one of the successful places. And then ABHIN with Caitlyn have had some good success in one of the FQHCs. And so those are positive. And Dr. Jason Onawa is on this call too, and he's one of the psychiatrists participating with that FQHC. But also I see Nicole Portrude and Amy Shields, who tried to help me get implementation through the Baptist system. So to compare and contrast with New York is that if you don't have the senior leadership of either the organization or the state, that's still, we keep saying that, but that is where the buy-in is. And so needing to get that and seeing how programs failed, but getting the buy-in of the PCPs, I think, is what's in the places that we see it successful. So I would say that that is very similar in where the successes are. Caitlyn, do you want to say a few things more?
I was thinking while we were talking about how to, so, you know, one of the questions in the chat was, you know, how do we advocate? How do we have conversations with the stakeholders that need to be in the room? One of the things that we've been really blessed with here in Arkansas is we've got a behavioral health champion and one of our state representatives that took the initiative to create a behavioral health work group that has been held for the last couple of years, and it's of her own her own doings, just her own concentration. She's just passionate about it. And she invited a lot of stakeholders to that meeting, whether it was state representatives or senators or a lot of the organizations that are providing this care, whether it's traditional long-term mental health care, residential integration, all of that were invited to the work group. And that ended up producing a really frank conversation because the questions that were being asked where, Arkansas has a high rate of SDOH needs, poverty, and obesity, and child welfare issues, that kind of stuff. And those questions were being asked of our state representatives. What do we do about this? And of course, talking about mental health came up with the discussion of integration. And we were able to, through that work group, discuss Act 615, which is where it was required that all private payers provide reimbursement for CoCM. So, going back to kind of what do we do, it might be helpful, we're talking about behavioral health champions with our primary care providers, but also talking about the advocacy at the state level of it may not be somebody with the DHS office itself. It might be a state representative in any part of the state that is passionate about mental health and asking and going to, so what somebody said something else about kind of peer pressure. And I agree. Those people will say, hey, you should come in and talk to this or talk and share in this conversation. You should hear what they have to say. So that's just kind of what I was thinking as far as advocacy. This is not a one person role, right? Like this has to involve every stakeholder in the state in order to really make any movement and encourage things like Medicaid and people like Medicaid to help with the sustainability piece of it. So I'm sorry, I know that was a long answer, but that's what I was thinking just listening to the conversation. Amy did a wonderful job. Honestly, there's a lot of points of I was like, yeah, us too. So I don't want to be redundant, but yeah.
It's so helpful to hear those different perspectives. And I know it's come up time and time again. It's easier said than done that social capital is so, so important. What are some areas that show you this is when we got the social capital and this is when we don't? What are some thoughts, lessons learned on the Arkansas side where there's been that buy-in and not from policymakers, and how has that impacted your work in Arkansas?
I would have to say it's been disillusioning to see the politics being behind the state. And so it was very much about the highest, leaders, thinking about the state budget. And so they can't really get down into the very nitty gritty of how CoCM can accomplish what they're trying to accomplish. So that, Amy, that's what I was trying to say. So what are they seeing is the ROI?
Eric put in here about peer pressure. Yes, peer pressure also got the other insurances online after we got BCBS on board, as they have the majority of privately insured lives in North Carolina. Share a little bit about what ABHIN does. I know about these pieces, but I would love others in this group to know what are the ways that you've gotten gritty and been able to really engage people in expanding CoCM in Arkansas without that maybe more traditional piece of first we turn on Medicaid codes. Share a little bit more about your work.
I have slides from the CFHA presentation. Dr. Gibson, do you want me to pull those up? That might be
Sure.
helpful. Yeah.
Sure. I would say, and even before the ABHIN got the grant or working with the state on the SAMHSA grant, was starting a stakeholder group that invited just anybody, including some of you all on the call, coming in and bringing external support, having that stakeholder group that began to socialize the concept of what CoCM is. And then Caitlyn, you're going to talk about the ABHIN involvement in this funding.
Yeah, talk about what our role is as far as in the grant. It's very similar to the technical assistance that Amy talked about. But one of the things that we, and this hopefully looks familiar to Dr. Sarah because she helped us with it. But one of the things that we did to help prepare the clinics that we're responsible for within this project is the organizational readiness tool. And that's where we had them do it on a whole systems level. And then on the specific clinic that we were asking to implement in to just their readiness and availability of staff and manpower and behavioral behavioral health champions. And it allowed us not only to see how ready they were, but what gaps that we needed to come in ready to help with. So that's one of the things that we did. We do it. Some things are going on with the grant right now, but we are preparing to expand within the FQHC that we already work with. And so we're asking them to complete this tool as well. And like I said, it goes over leadership and readiness, what their patient makeup looks like. Do they have any history with integration? And kind of what's the buy-in? I mean, what's the finger on the pulse kind of thing? Does your staff know anything about integration? Are they ready for it? Are they interested? And another aspect too is like, well, how much education is needed? Because to what Amy was saying is like, this is really primary care driven. This is not and it's got to be explained to them in a way that we're here to help supplement what you're already doing, not to hand off your patient to us and we'll call you in about 8 months and tell you how they're doing, so this is just an example of what it looks like. I don't want to spend too much time on that. Okay, so this is where we're at right now in our program. We're doing technical assistance for a couple of different places. Over there in East Arkansas, you can see that is where our first implementation started. And they serve West Memphis, but they also serve, there's a couple of metropolitan areas in Arkansas, not many of them, but they are in West Memphis, which is considered one, but we have a lot of rural areas around there that people drive into to receive care there. And then down there in the Delta, McGee, and then over here towards the west part of the state, River Valley Medical Wellness. And in fact, again, to the point of you don't have to choose one, one size doesn't fit all as far as integration. You can have multiple levels of it. It's not just CoCM or PCBH that has to exist. River Valley actually has all 3 levels. They have co-located PCBH. I have my own intern there that's a PCBH intern, and then CoCM is starting. So we've got such a wide variety, and we help them a couple of different ways. Is we do, like we said at the beginning, we help with the training, the onboarding part of that. We teach them not only as BHCMs how to do those brief interventions, how to do a warm handoff, etc., but we also teach them how to work with the psychiatric consultant. And then we provide bi-weekly coaching calls. So every other week, the plan is to have them meet as a group one week and then individually the next, so we can create that peer network that outlives the grant, right? Like we want to be able to establish those relationships across the state, because look at how diverse these places are in different parts of the state. We want to be able to leave them with the framework to bounce ideas off of each other, and then able to do some kind of problem solving, some brainstorming should they need it at those biweekly calls. And then we've already mentioned the stakeholders call, which stakeholder sounds like such a big formal word. Anyone's invited to that. If you live in Arkansas, you're a stakeholder, right? Or if you live in, if you have an interest in integration at all, you're a stakeholder, right? And then office hours right now, we've had a pretty good attendance for office hours. I say good attendance is 5 people because that's a party and we can talk about integration at that point, right? So we've had pretty steady right now, and that should be picking up soon in the next next month or so again. So I know we're probably close to time. There is a curriculum that we base off of. These are just some examples of what we go over with them in a 2-day training. Do about 8 hours both days. Just kind of talk about what CoCM is, what that brief intervention looks like, and then what it looks like to work with a psychiatric consultant and what their role is in this. Again, we're not handing the patient off to that psychiatric consultant, right? We have to really educate the primary care doctor on that, and the support staff on that as well. So, and then finally, we do have one of the responsibilities that we have as technical assistants in this grant is we provide an active website for these CoCM efforts in Arkansas. So there's a portion of our ABHIN website that you can go to that has all of our recorded stakeholder meetings. We don't record the office hours because we want people to feel safe and comfortable coming in and asking their questions and being vulnerable. And then all of our CoCM webinars, anything that we've had that involves any kind of integration is live in there. So we've got a lot of different components in this. And then our counterpart UAMS is working within their system and doing it in their ambulatory clinics as well. So, and we get to meet with them monthly and get to brainstorm with them on their problems and ours. And it's exciting to see what everyone is doing in the state. So I'm going to stop there. I talk really fast. I'm so sorry if I was talking too fast there. Let me know if I need to repeat anything.
Amazing work. And yes, this is recorded so people can go back and watch again. Any final questions from team members? We got 2 minutes left for New York State or Arkansas case study examples here. Yes, we love our woven decks. Shout out to the woven deck supporting in Arkansas. Great example of psychiatric consultation spreading across the country. Go ahead, Patty.
I was just going to say, and continuing the CFHA and having the CoCM SIG and the website to be able to continue to come back and learn pieces. It's like it's a continued iteration and learning, even when you're the one doing the training.
You got it. This is why we're here to support one another. So use the Basecamp. Feel free to reach out to Amy or Danielle, Patty, or Caitlyn on Basecamp. You can find their contacts that way. I added the ABHIN website here. Just outstanding work being done across the country, and so thankful to be a part of this group with you guys.
Thanks for having us.
Thanks so much. All right, everybody, we'll be sending out notification about when our next meeting is going to be for the new year, but this is our final one for 2025. It's been a wonderful year with everybody, and please reach out to any of us if there's topics that you'd want to hear more about. I wrote down and added to our leadership Basecamp. We're going to have a 2026 coding request. So let us know what you're wanting to see more of. This is how we support each other. We let each other know what's going well. We let each other know what's been challenging and use one another as social resources to help spread CoCM. Happy holidays, everybody.
Thank you.
Good
Good to
to
see
see
you.
you.
Thanks.
Happy holidays.
Bye-bye.